So we've been charged to talk about something politically charged with some speculation around what may be coming over the next few years, so bear that in mind. Obviously, it's a very relevant topic, and I'm just going to sort of frame the discussion a little bit here. We all know that under the Affordable Care Act, one of the goals was to expand health insurance coverage. One of the primary mechanisms to do that was through Medicaid expansion. And the approach was to really push that to the states, but to have some federal dollars attached to that to sort of incentivize expansion. Of course, that was very uptake depending on the political climate of the actual state. And just for the folks that are out of town, because this may come up in some of our discussions here, so the state of Michigan has a Republican governor, but we expanded Medicaid a couple years ago. The plan's called the Healthy Michigan Plan. And of course, this is all timely because with the recent deliberations within Congress around potentially repeal and replace under the American Health Care Act, one of the targets has been Medicaid. And the recent Congressional Budget Office score on that from about 6 weeks ago suggests that in about 10 years, 24 million or so may lose their health insurance coverage. Very much a lot of that related to Medicaid. Of course, that's in the hands of the Senate now, and I think we'll see what the most recent iteration of that bill looks like because the score from the Congressional Budget Office is supposed to come out tomorrow, actually. So we're going to tackle this from a number of lenses. We're going to be talking about acute care broadly. So not just ED focused, not just ambulatory care focused, but across the continuum. And we'll see sort of how far we get in these conversations, and I'd like to have some audience opportunity to ask some questions. But the first question we're going to ask is around access. So how would potentially Medicaid rollback affect access for care, for health care, for acute health care needs? So I'm going to start with John Ayanian, who's done a lot of work with assessing the Healthy Michigan Plan. What are your thoughts about this?
So here in Michigan, we've had about 650,000 people covered under the Medicaid expansion, and we now are beginning to have survey data. We're working with the State Department of Health and Human Services to evaluate that expansion as part of their agreement, the waiver that we're operating under with the Centers for Medicare and Medicaid Services. And what we found is the beneficiaries who have enrolled in the Medicaid expansion tell us they've had substantially improved access. And I think relative to acute care, we find that in the first year after enrolling in the Medicaid expansion, about 15% of the enrollees told us the emergency department in their community was their main source of care before gaining Medicaid coverage. And those same beneficiaries tell us after gaining Medicaid, that was down to 1%, which doesn't mean they stopped using the emergency department, but it means that the efforts to extend access to primary care are beginning to work in the state. And Caroline, who works in a family medicine clinic and directing their efforts, I think can comment on this as well. But we're seeing for more chronic conditions and preventive services, people making much more appropriate use of the healthcare system and hopefully getting in sooner, although we're going to need to track that, whether that impact on access translates into better health outcomes, because the literature that we have to date suggests important ways it does, but not necessarily consistently across the board, and it really depends on not just the access that people have, but the quality of care they get once they're in the system to determine whether they get those better outcomes that we're all hoping for.
I was wondering if maybe Tim, if you'd go next from your perspective as a leader within an accountable care organization responsible for the total cost of care for a population. Yeah. What your thoughts might be about rollback of Medicaid and how that may impact access for acute care.
Sure. Well, I think, so riffing on a little bit what John said, you really touched on two pieces of access, and that's, is there a willing provider, right? And so if you don't have insurance coverage, you don't feel as though you have a willing provider because you don't really want to pay that out-of-pocket expense. And you could debate whether emergency medicine physicians are willing providers to an uninsured population. We're a mandated provider for certain, right? But when you have that insurance coverage, then the affordability becomes less of an access barrier. And I think we sort of potentially lose track of both of those things. So the ability to get into an office, is there an available slot? Is there a doctor in the primary care world that's willing to take care of you? And then the affordability piece, and I don't remember who wrote the article on it, or whether it was even a news publication or a research publication, but I mean, the Affordable Care Act was one of the single greatest pieces of legislation that changed bankruptcy rates in this country, and it was really around healthcare bankruptcies, right? So taking that away from folks will diminish access from an affordability standpoint. It will diminish access from a willing provider standpoint. There are not enough federally qualified health centers. There aren't enough free clinics in the world to take care of the uninsured patient population in our country. But more than that, it's going to change significantly what we see. We're going to go back to what we saw before in emergency medicine settings, which is I routinely diagnosed breast cancer in patients as an emergency doctor, right? I routinely saw sort of end-stage disease processes and all of those sort of health outcomes that we have begun to get some traction on and begun to see improvement across populations are things that, I think without a doubt, we're going to watch a slow and steady march back to where we were before.
Yeah, I agree. And I think what you've seen from a system perspective within our own system is we've seen a significant reduction in patient pay and in charity care here that has been replaced with Medicaid reimbursement. And it's been not necessarily a one-to-one, but it's been a significant correlation between that reduction. And I think that, just speaking from experience and Tim's experience too, is that with charity, with self-pay and with charity care, I think you see people later in disease states, we are able to provide less of that for them. So as you strip away this benefit from Medicaid, that's provided through Medicaid, I think you're going to see people presenting later, and we're going to be able to offer less access from a care perspective, right? Medicaid is not a great payer for us, particularly in emergency medicine in Michigan, but it's better than nothing. And so and it's better than us having to provide charity care. And so it allows us to subsidize other care that we might provide or provide broader access from a systems perspective. I think the other thing, just to kind of, dig into the political aspect of this a little bit too, is, the Medicaid expansion was states' response to how to meet some of the requirements or take advantage of the ACA, but it's really not related to the ACA Act in and of itself. And so this is a little bit of political, nuance to start linking the reduction of Medicaid to ACA. You could repeal and replace the ACA and do nothing with Medicaid at all, right? And then it would play out through states. But there's some conflating of what the issues are, depending on what your political bent is, as to why they're linking these two things together.
Caroline, I don't know if you want to speak from like a primary care perspective.
Sure. So first, I really appreciate that primary care is in the room here. I think it's an important part of managing acute care systems from a bigger picture. And just to build off of what you were saying about the conflation of the Medicaid policy with the ACA, there's actually parts of the ACA that really do have a big impact on Medicaid, and particularly on the most vulnerable patients on Medicaid. And those directly address the dual eligible population. So patients who are both old and poor, or both disabled and poor, are eligible for both Medicare and Medicaid. But Medicare is not really set up for poor people. And if you have Medicare, but you don't have any money, you often can't access those services. Medicaid comes in and fills in some of those gaps, paying for deductibles and copays for the poorest patients, but also filling in with addressing some of the social determinants of health that we've heard before, and some of the uncovered services, like services for hearing impairment, for dental, for vision, that help people be able to lead productive lives and not get injured, not end up in the ER for other acute care service needs. And I think, if we see, the ACA provided a lot of ways that coordination of care between Medicaid and Medicare could be improved, provided a lot of funding for coordinating agencies, for care coordination systems, for pilot programs trying to improve the care of these most vulnerable patients. And some of that may be rolled back if Medicaid expansion is rolled back. Some of those patients who obtained that support of being dual eligible will no longer be dual eligible. And these are our most disabled, most chronically needy, most expensive patients. They will end up back in the ER.
Let me just add to Caroline's point that the American Health Care Act is not just about repealing the expansion, but by instituting a per capita funding model would actually take a lot of money out of what would otherwise be the expected funding for Medicaid. So it does set up some of these potential trade-offs and conflicts, for example, between services for poor children and disabled nursing home residents, or between working age adults in the expansion who maybe are better able to work if they're covered and less so is what we're finding if they're not covered. So, there's more to, as Jeff was saying, this potential rollback of the Affordable Care Act has a much broader reach as it's currently structured, and with the understanding that we don't know what will happen at the Senate at this point. Every day sort of the prospects change, and I think the Congressional Budget Office score that you mentioned coming out tomorrow will be another big milestone, whether that allows the bill that passed the House to move forward.
So I'm going to throw out a question out, that's not quite on our list here, but I'm still curious to know from the panelists, do you feel like, if you sort of think about this from acute care delivery and helping patients with acute care needs, do the panelists feel like Medicaid expansion was a net positive for those things? And do you worry about the future potential state that we're sort of actively kind of debating now within the federal government? Or were there other ways to sort of address managing those kinds of problems?
Net positive or?
So, well, there's no question that people got care. I mean, sitting in our clinic in Ypsilanti, people came in every day who hadn't seen a physician in 15 years, and now they had insurance, so they came in and they had problems that had to be dealt with that potentially prevented a hospitalization. There's no question about that, and it was on a massive scale, not on a small scale. So, as far as care for the patients that needed it, there's no question that it was a net positive, at least for the very vulnerable populations.
I think that's one of the crux of that question, I think, sort of speaks to one of the common misperceptions about ED utilization, right? So we often hear people talk about people using the emergency department as a primary care site. We give tetanus shots, but we don't give flu shots. We don't do chickenpox vaccines. There's a lot of things that we don't do for primary care services in emergency medicine. People, I don't recall seeing a bunch of mild asthma exacerbations, which is a very primary care sort of thing, right? So I think it was absolutely a net positive in that we would catch folks earlier in their condition. Maybe they didn't see us, maybe they saw a primary care doctor, maybe they did still see us, but the net effect was that we were able to treat people earlier and therefore avoid hospitalizations, avoid ventilator days, avoid any number of late-stage complications from their disorder. We probably also picked up a bunch of acute exacerbations of chronic disease, things that people were sort of let smolder. If you have your diabetes and your blood sugar is 250, assuming you somehow know that without insurance and a glucometer, you probably kind of tolerated that at home when you couldn't afford care. But now when you have a way to afford your care, you recognize this is not a good state for me. It may not be what we think of as sort of more traditional acute care, although it is an acute exacerbation of their disorder. But all of that sort of allows us, again, to treat earlier and help people live better, longer lives.
And what do people feel about this potential, I think, criticism, so on the opposite side, which would be, there's pent-up demand. When you expand health insurance, you sort of create demand that may not have been there in a way that leads to cost-effective care. That we're just sort of opening the doors to utilization that necessarily doesn't drive value. Does that resonate with anybody, or is that something that people sort of feel like would sort of dismiss as a criticism without really basis?
There's evidence, for example, from the Oregon Medicaid lottery from about 7 or 8 years ago, where the expansion did lead to a sustained increase in use of emergency departments. I think what we haven't really had a chance to see is to what degree that's appropriately increased utilization, and to what degree it was related to potentially barriers of other acute care sites, urgent care centers, primary care offices. We've seen in Michigan, there was a big concern in Michigan that there was not enough primary care capacity to accommodate the Medicaid expansion. And in fact, one of our faculty, Rena Tipernini, as a clinical scholar, did some very strong research showing essentially that as Medicaid expanded, more primary care offices were willing to accept it. I think in part because there was a bump in primary care fees tied to the Affordable Care Act, but also I think physicians and communities realized this was going to be a more substantial part of their practice, and so they were willing to commit to serving those patients. And it's still a lower rate than, for example, with private insurance or Medicare, where 80 to 90% of primary care offices are accepting new patients, compared to only about 55% for Medicaid. But that 55% was actually a bump up from about 48% prior to the Medicaid expansion. So to some extent, getting people covered is I think, helping the system to adapt. And for example, we're seeing greater use of nurse practitioners and physician's assistants, and that's partly how primary care offices handle the surge in both preventive and acute care services they're providing.
And I think that's some of the experience that they saw in the Massachusetts model when they first rolled it out, that the increase in ED utilization was fairly regional, depending upon what the capacity was to have additional care providers in that area. And so in rural areas and areas where there was limited care providers, they saw a higher increase in ED utilization. But in areas where there were more options, they saw, and over time, it leveled out and they saw less of that. So I think, I would go back to, Carolyn's statement that if you give people coverage, then they can get care. I think that is the ultimate premise of this. And the argument that there is pent-up demand for care that we shouldn't cover because we're not covering it now, I don't see the logic of it. I mean, I think some of that care, the care is needed. I think we have to be judicious and we have to be careful about how you supply that coverage so that you can route care in the most appropriate way. But, just the idea that because we're not covering it, the demand is somehow not valid, I think doesn't make sense to me.
Yeah, I also think that the patients that we're seeing coming onto Medicaid through the expansion are not patients that are aggressive seekers of excessive medical care. It tends still to be an effort to convince them to take care of themselves, to get the chronic care management, the preventive services that they need. It's not like they're jumping at these services. Partly because of a cultural preconception about medical care, but insurance coverage is one necessary component of getting appropriate preventive care and appropriate chronic disease management, but it's not the whole story. And we've talked about the problem of access of capacity in the primary care system needing to ramp up a little bit. But there's other issues too around what are we doing for these patients in primary care? Is it effective? Are we actually doing the right things to prevent the diseases and the hospitalizations, the ER visits? Are we providing care services in a way that they can access them? One thing is, payment models haven't changed that much, although there's been a lot of talk about payment models in primary care. They really haven't changed that much. And frankly, it's not profitable for a primary care office to leave a bunch of open urgent care slots. We'd rather just schedule everybody and get the full payment for big preventive care visits and leave the urgent care to go to the ER. From a cost perspective, that makes more sense. But it doesn't make sense from a big picture. And so there's a lot of different system level changes that need to happen to actually realize the full potential of covering people. But certainly covering people is a step in the right direction. And it's necessary, maybe not sufficient.
I think one other point that's important, that Jeff touched on this earlier, is that when you expand coverage, the organizations providing care become healthier financially, and there are spillover benefits to the whole community. And there's evidence going back 10 or 15 years, for example, that communities with high rates of uninsurance are less able to sustain trauma systems and other programs that serve everybody in the community relative to those with higher rates of coverage. And so, in the states that have accepted the Medicaid expansion, in general, we're seeing, for example, the sharp reductions in uncompensated care, charity care. Here in Michigan, we have data that shows that it's gone down by nearly half from 2013 to 2015. And that really, for hospitals that are just barely in the black or functioning in the red, that can change their hospital margin by 3% and basically, change their whole ability to provide the services that they want to offer.
Or even to leave a provider in a community, right? I think that's the other piece of that, is that there's another, with that financial health comes the ability to have, just yet another provider of healthcare in a community where it may have otherwise been reduced or completely eliminated from that area.
I want to have some time for audience questions, if there are any out there. I certainly have some more for the panel, if not. But we have 15 minutes or so. Any questions so far come up in any people's minds? Yes?
From a leadership perspective, I'm curious what sort of lag times you're seeing and how you approach decision making with uncertainty. Because I am surprised a little bit that you're seeing such tangible benefits, or you have seen so quickly here in Michigan from the ACA change. In Massachusetts took us, I think, a little longer to see some of the changes, but it sounds like a lot of decisions, a lot of care delivery choices were changed pretty quickly when the ACA came on board. And I'm curious how you approach it from a leadership perspective, wondering whether it may go away and how you're approaching that uncertainty now.
So is the question, how quickly do we make leadership decisions? Because I think I would leave it to you guys to answer that. Yeah, that's the hard part, right? And you know, that's the other, so I'll try to give you a more specific answer, but I'll give you a general answer as well. Just, again, a little more political perspective is, you know, what happened with the implementation of the ACA was a lot of messaging, a lot of what's going to happen in the future. I mean, the healthcare system as a thing was hearing about what was going to happen with the ACA, meaningful use, all this stuff, long before it ever came into effect. So the kind of playing of your hand so that the industry can start to plan and start to change and implement those things. And that's why even by the time, you know, the ACA actually passed and was implemented, the train was well down the track, right? So the idea that you are going to, not you, but that you know, we will all of a sudden turn off the switch and that the train is going to jump to another track is just a false belief, right? I mean, there is so much built into this, and there's so much inertia in the healthcare system that it's going to take years to unwind what has already been built, whether you like it or not. Now, you can do a lot of drastic things that will create chaos, and my prediction is, you know, that business systems don't enjoy chaos, and they will push back very hard when that looks like it's going to be the response. So the answer is it takes us time to understand what the implications of the legislation would be, and then to put effective plans in place for that. With the amount of variability and the rapidity of change, we honestly are not really clear on what's coming, and we're waiting for clarity before we start doing anything. We're starting to do some modeling to say, what would it look like? How do we think we need to plan? What does that mean from us from a financial perspective? But to actually think about things that you're going to implement that are either going to be countermeasures or take advantages of positive change, if there are any, it takes a long time for that to happen. And unless there's clear messaging early on, you can't plan for that and plan for a smooth transition. And I think that's going to be the biggest pushback you're going to see about this whole change, is that the industry just can't change that fast. And I don't know, Tim, from your population perspective, if you have different thoughts.
I think one of the reasons that you hear more from us that sounds like we've been successful or been actively engaged in a lot of this work is the University of Michigan has always taken a sort of all patient, all payer approach to work. We've rarely specifically tried to segment programs based on payer. Mm-hmm. And I think that's given us more flexibility to expand existing programs because we had a lot of this already in place. And so extra funds have a natural direction. And we're not actually building whole new programs, but we're maybe better funding or better staffing programs that already existed. So.
I also think we were involved in a lot of the pilot programs that built the legislation.
Right.
And so we actually were delivering the data and the knowledge to the rest of the state, but we already had some of these projects going, already had them staffed up, and already had learned quite a bit from them. One of the things that's about to happen in Michigan is that the governor has said that we're going to privatize mental health care and give about $2.5 billion in funding for community mental health to the Medicaid HMOs to manage. And we've successfully pushed back the date for that implementation to allow for some pilot projects to happen to see what actually happens when we do that, and what are the implications for care, for ER visits, for the seriously mentally ill population. And so we will likely be involved in those pilots, and that will give us a step forward. Some of the other regions in the state may not be quite as ready to take up and adopt the new legislation.
Any other questions from the audience? I'll stand in for a question. You know, one of the things that we've skirted, I think, the surface on is around costs. And, you know, costs is always sort of problematic to have like a conversation around, because it's like sort of what costs, whose costs, who owns that. But if we just sort of think about delivery costs for acute care in a current state versus a future state where we lose Medicaid expansion, what does care look like in the future state? And what do costs look like?
I would argue, and I'm actually interested in your perspective on this, since you sort of sit at a very different level of the organization than I do. I'm not sure that our delivery costs actually change all that much, and I think that's the fundamental problem, right? Is we're taking away the revenue that allows us to sustain ourselves, but we still, especially as an acute care delivery system, whether it's primary care doctors, whether it's emergency doctors, whether it's trauma surgeons, we still have a fundamental contract with the community about the services that we're going to be able to provide. And the staffing levels it takes in order to be able to do that don't really change that much based on the insurability of the population that we are serving. So my argument would be that the service delivery costs, there will be some moderate changes, right? There'll be smaller patient volumes because there's less insurance availability, and therefore you need fewer doctors and nurses and PAs. But in general, I think that's a trivial amount of the total delivery system cost, and I think we're actually looking at running back into much slimmer margins and potentially negative margins for a period of time. But that's, you know, that's just purely speculation.
Yeah, I would agree. I mean, I think the challenge with a big healthcare system is that the cost to demand ratio is pretty inelastic, right? Our care model exists, and so the cost of care delivery does not change much based on the demand for the model in the short term. Now, in the long term, that's part of the equation that you have to think about. You have to think about how do we design ourselves that we can provide appropriate care at the lowest level of cost in order to be financially viable. But I think it's going to come back to, you know, what's going to happen. So if Medicaid is reduced, they're going to do one of two things. They're going to, or both, probably both, which is bad, but they're going to cover fewer lives, or they're going to provide fewer benefits, or they're going to provide fewer benefits to fewer people, which is going to be likely kind of what happens. And so I think from the cost perspective, it's not going to change dramatically our costs of care delivery, but we're going to have to look at what either businesses we're in, or how do we design care in order to be, you know, more cost effective in that environment. And you've seen that on the inpatient hospital operations side over time, over the last 10 years, is declining inpatient utilization and attempts at lowering inpatient cost utilization, you know, related really to reimbursement, and that's been driven a lot by reimbursement. But in our model, being a institution that has a strategy around providing complex care here, that limits our ability to reduce that cost model to say, you know, what a small community hospital is going to look like.
So just to carry that one step further, right? So if you buy into the premise that our costs to deliver care, our system delivery costs are relatively fixed, you know, the teaching or the sort of adage has always been that health systems want to sort of break even on Medicare, and you make your margin on your private insurance dollars. So affordability of private insurance, the costs that we charge insurance plans, or the reimbursement that we receive from insurance plans, is going to necessarily go up in order to keep us afloat. So we'll have a negative impact on affordability on the private market. Payers, employers, who are the bulk purchaser of most private insurance, are already, you know, suffering and also seeing multi-digit increases in premiums, but that's going to be exacerbated. And I don't know that necessarily, that math is complicated, that math is hard to explain to a general populace, let alone a politician. I don't know that really has been given much thought in this conversation about cost cutting, which is really all about federal spending cutting, right? So.
Right, and with that, I think in the private insurance market, we'll see a move towards narrower networks and tiered networks and higher, high deductible health plans, which were already rising prior to the ACA, but would accelerate, I think, if some of these pressures play out, and as a way for employers and private insurers to try to keep total spending sort of more level, and that means the volume of care is going to necessarily go down because the prices will be going up.
And in essence, those things just push risk towards the patient, right? So they think that's the fundamental model there, is you increasingly make the patient responsible for risk. But in our environment, particularly acute care and the ED in particular, the patient ultimately doesn't carry the risk, right? The community we carry the risk because they're ultimately going to come for care. We're ultimately going to provide them care if they present. And so, that idea that that you're going to change people's health behaviors to some degree by having them carry more of their insurability risk, I'm not sure always plays out.
Yeah.
I'm curious from a pediatric standpoint, Medicaid coverage was pretty good for kids in Michigan before the expansion, and as we've now covered more individuals with adult chronic conditions, mental health disorders, substance abuse, that kind of thing, as people are having these conversations about pulling back and containing costs, where do you see children faring in the state?
Well, I do have, I'm going to apologize because I have to leave. I have to run to campus and start something in just a little bit. But it's not just because I live with a pediatrician who happens to be the president-elect of the APA that I will say, children will be disproportionately disadvantaged likely. So kids make up 54% of Medicare dollars in Michigan, Medicaid dollars in Michigan, and 40% of kids in Michigan are on Medicaid. 40% of our reimbursement to Children's Women's Hospital is based on Medicaid, right? So you start stripping it away, you're going to be making choices between what you're going to cover and who you're going to cover. In contrast, about 14.5% of adult services at UH are covered by Medicaid, right? So, you start stripping things away, you're going to feel it much more on the pediatric side and in the children's side, unless you do some very specific things and are very careful and clear about how you reduce that care. So it's going to come down to who do you not cover any longer, or what services don't you provide to that smaller population. And I think pediatricians are right to be worried. We've not approached a reduction in Medicaid since it was really initiated, almost, 60 years ago or whatever, right? I mean, it has been to the side of these discussions around Medicare and other control of costs within healthcare, not costs, but expansion of healthcare. And so this is a new era I think it does create that risk.
So although it's, what you just said is true, there is stuff in ACHA that explicitly protects children, pregnant women, and newborns in the first year of life, which really means that if you can't cut those are mandated even in the block grants to states. States don't have the authority to reduce coverage for those groups, according to the current draft. So that means that the adults are actually going to be disproportionately disinsured if that protection remains.
Well, we talked earlier, though, the coverage is a piece of access, right? But a willing provider is the other piece. And so, while they may try to preserve some access to these things, you can sufficiently cut reimbursement for pregnant ladies such that there are 0 providers available in any given market, and that's not going to have a positive outcome for anybody's kids. Right.
And the other complicating factor is that the Children's Health Insurance Program, or CHIP, expires at the end of September, and Congress basically has 3 months now to reauthorize it. They may not take it up till July or August, and in fact, the states have said they're going to have to start sending termination notices to families of children covered by the Children's Health Insurance Program, as early as late June or early July, because if they don't know the federal government is committed to continuing that program, they have to have a fallback plan in place. It's the question of how much time it takes for systems to ramp up, but how quickly things could fall apart. If Congress is falling behind on its work. And historically, the Children's Health Insurance Program has had strong bipartisan support. It was Orrin Hatch from Utah and Ted Kennedy from Massachusetts that really pushed that forward when it was enacted. And I think that bipartisan support is still there, but then it's caught up in this sort of paralysis around the ACA and what comes next for the Affordable Care Act.
So we only have 2 minutes left. So I don't know if anyone wants sort of a final thought out there. We can also sort of end our time as well.
I have have a question.
Oh, sorry.
So yeah. So looks like a Senate vote on the AHCA or some form of it is going to be inevitable eventually. So what is our charge, in your opinions, as clinicians and researchers, so to change minds maybe between now and when that vote happens?
Find influential senators and call them and their staff. Yeah. I think there's an evidence base for both the benefits of the ACA or coverage expansion and what can go wrong. If a not well thought out plan is substituted for it. I think we just, have to heighten our efforts to use the evidence that we have and that, through our professional organizations, through our university, through community groups. But in the end, it probably comes down to a fairly small group of senators. I think there's a group of a dozen or so Republican senators, and really the debates between sort of the moderate and more conservative wings of the Republican Party right now, sort of how much to change and how quickly to do that. And to the extent that we can sort of contribute to that debate, I know you, Mashid, have been very effective in writing op-eds, for example, and I think that helps to shape the public perceptions of what's at stake. And speaking both from our research experience as well as the clinical roles and the sort of leadership roles that we have, I think that's, data only goes so far. It goes back to some of the earlier points about mixed methods, that we have to be able to tell stories that bring the data to life and about who's affected and how. And a lot of it, comes both from our research as well as our clinical work.
I think one of the difficult things about advocating against this new legislation is that it's complex. And the ACA is incredibly complex. ACHA is also complex, is so multifaceted. There's so many little parts of it that people don't even know are in there, and people are just getting their hands on. Things like Medicaid. One of the things in the ACHA is that Medicaid will no longer be able to pay Planned Parenthood nationally. And that has a huge impact on access to primary care, especially for vulnerable populations. And that's just one little paragraph, one little sentence, really, in this very complex set of legislation. So there are all these pieces that are going to be implemented in this one bill, and effectively advocating against each of those things that could negatively have a negative impact on population-level health care and on acute care services is difficult. It's complicated.
Yeah, I think the key is really driving home the impact it has on individuals and on our patients, right? What I read that is around healthcare financing and around hospital finances, none of that resonates with anybody, right? Patients don't care about the CEO's take-home pay. Nobody cares about the hospital's margin. There are no doctors in bread lines yet. So none of the financial aspects on the macro level are really going to move anybody's needle on this issue. It's really going to be bottom line. And I think that's part of what you see when you see the articles around senators in their town halls and congresspeople in their town halls and individuals standing up telling their story about how their access to coverage saved their life or their spouse's life or something along those lines. The ways in which we can bring those at a larger level, individual stories are great, but advocating for those en masse and demonstrating large population level impacts of coverage are the things that I think people really need to see the most.
I think it's a great way to end. We're out of time. I really appreciate all the panelists. Thank you.